have a panel on the rollout of national PharmaCare. I know it's an issue that nobody in this audience cares about. So let me quickly introduce the panelists and then I'll ask them a few questions. So we have with us Declan Hamill. He's the VP of Legal Affairs at Innovative Medicines Canada, IMC. Christian Ouelett is VP of Corporate Affairs at Sandoz Canada. Laura Syron is President and CEO of Diabetes Canada. I hope they're going to come up. I'm introducing them. And Joan Weir, VP of Group Benefits at the Canadian Life and Health Insurance Association. If you all want to join me on these very comfortable stools.
We're not sure when the cue was to come in, or I'm trying to get in the same order that we were. So here we go.
Side, Andre?
Yeah. Okay.
Great, so welcome everyone. Laura, I thought I'd start with you, start with the patient perspective. We've talked about it already a couple of times this morning, how important it is. From a patient perspective, you know, we have PharmaCare now. We have Bill C-64 was adopted earlier this month. This is fairly new. From a patient perspective, is PharmaCare a good thing? A, and B, is this PharmaCare a good thing?
Yeah. Terrific question, Andre, and probably two different answers. So first is access to medications for people living with diabetes and also for people with contraceptives, really important. At Diabetes Canada, we have a 1-800 line. The number one call, especially since COVID, is about financial assistance for medications. Over and over, including even now copays. I can't even afford my copay. So PharmaCare, access to medicines and hopefully devices, although that's not in PharmaCare but it's separate, is really important. The issue, of course, is whether this PharmaCare, there are some concerns that we have with the legislation, or with the bill now as it's written. But in general, we're supportive of something that allows people better access to medications, because we know if you have access to medications, you're going to have a better outcome and the future complications of diabetes are a lot less. And I should let everyone in this room know, not only do I sit here representing the 4 million Canadians who live with diabetes, but I'm one of them. I live with type 2, and so this is really personal for me as well. But as you said, Andre, some of the issues here are the list that's accompanying this is not very comprehensive. A lot of people call us and say, but my medication's not on the list. What does that mean? And then, of course, what we're calling do no harm. We don't want unintended consequences. People who are on private plans that have good coverage now, we don't want them to get bumped off of that, and that's not clear in this legislation.
Yeah, and there's very little clear in this legislation. That'll be a lot about what we talk about today. There's more questions than answers, but you all have expertise, so we're going to do some guessing and whatnot to talk about some questions that have to be asked. So I'll switch Christian Ouelett. I'll ask you the same question, but more, I don't want you to speak for the whole industry, but sort of an industry perspective. PharmaCare a good thing? Is this PharmaCare a good thing?
In fact, PharmaCare is a good thing for access to people who don't have currently a coverage, and I think everyone in this group here would agree with the fact that we need to provide coverage for patients or people who don't have access to. The question really is that type of PharmaCare will really work, and is the role of the federal government to implement it? First of all, and also there's a lot of more question than answer today that you may ask, but we don't have the answer. And how is it going to be the deal with province? How is each province will react? What's going to be the interaction with their own formulary, with the national formulary? Which disease will be covered next? So that's going to be, if I were a patient and look at the thing as, oh, my disease is not covered in the current PharmaCare, will I be in the next wave? You know, that type of thing. So you can imagine that the way it has been set up raised way more questions than answers. And this is why we would have preferred, on an industry point of view, that before the federal government move on that file, I think good intention, but actually not really good policy for implementation point of view.
And I guess we have to ask here, what is the definition of PharmaCare? There are many definitions, right? Like the government seems to be covering everything publicly, but that's not necessarily what PharmaCare means in other countries. Oh,
yeah, you're absolutely right. And the fact that we were quite surprised when the government announced that it's going to be a universal plan, rather than being like Quebec model, would share with private and public insurer. And secondly, that the first dollar will be paid by the government. We were quite surprised as well by this because the budgetary impact is significant. So you're right by saying what's the definition. It may we raised those questions, and unfortunately during the consultation there was not even a single amendment that has been made in the C40 64. Based on the fact that we asked clarification and we didn't get the answer.
And universal doesn't always mean everything's covered either. We don't know what'll be left off. There are always limits to these things. So.
Yeah. Yep.
Now, Joan, what's the interaction going to be between public and private plans? Do we have any idea?
No, I think that first of all, we agree that PharmaCare is important to our country so that people without coverage do have coverage. So I'll say that first, but what will the interplay be? So unknown at this point in time. Based on the way that the legislation is written, it could be that those two categories, private payers have no place in paying anything. So that's probably the strictest interpretation. Another interpretation could be that insurers, private payers can pay for anything not listed on the drug list that they've provided or they will develop further. And then I've heard it say, today we do interact or integrate, I guess, with public payers in terms of paying co-pays that potentially aren't paid or excess dispensing fees. That happens today, but will it happen with this, which is part of the Canada Health Act? It's unknown. So many unknowns with no answers. It's hopefully we will figure it out over the next period of time as provinces and territories negotiate with the federal plan, but we will see.
And we had something like this with OHIP Plus in Ontario, the coverage of kids. There was a big problem with the interaction. Do you fear this being a repetition of OHIP Plus on a grander scale?
Very much so. So we've been glancing back at our OHIP Plus experience a number of years ago now. One of the things that was assumed at that time was that prescribers would automatically migrate to the list of drugs prescribed. And this model, insurers had no place in paying for anything that was on ODB for 25 and under 25. But the migration of prescribers did not happen. And so OHIP Plus was left at the last moment asking private payers, the insurers, to continue paying for drugs in a transition period, which of course never ended because it was eventually changed to those with no coverage. And then we had to unwind it all. So you've got prior approvals that have to be done. You've got prior approvals that may have to be unwound. It was a significant amount of work for what ended up being a program for those without coverage, which would have been a lot easier to implement. But yes, we feel that there's a possibility that this could end up, and given that provinces and territories are going to be able to negotiate what it is they want, it sounds like, it's going to be very complicated to put in place, that's for sure.
Now, Declan, thanks for your patience. There's a lot of us on the panel. There's a lot of talk about universal versus fill in the blanks. What's this new law going to do? Is it going to fill in the blanks enough? Is it eventually going to be universal?
Well, thanks for the question, Andre. I'll go back to my legal training. What matters is what the Act says, right? At the end of the day, the minister can say things about what will or won't be covered or what the intention is, but the Act is fairly specific in terms of it being first dollar, single payer, universal. So that could change perhaps over time, but they will be guided by the legislation. It's now the law of the land. So our preference as IMC and our members would definitely have been towards more of a PEI-style fill-in-the-gaps solution, which we believe would be cheaper and more effective at getting what we want, which is better access to innovative medications for Canadians, as opposed to what the sort of universal model. At the end of the day, we have system which has evolved over time with private and public plans. Going back to the keynote speaker, Canada already has, from a comparative international perspective, a dearth of availability of innovative medicines. And when they are available, they take a long time to get to patients. But it's even worse for public plan members than private plans. Private plan members get a lot of medications which aren't available on public plans. So, from our perspective, if the outcome or the rolling out of this legislation is to impact private plans, that's not a good thing, because they are already the people who have more comparable treatments available, based on international norms. So, the rollout of this is going to be very slow. There's a very small defined number of medications. Is there leeway for provinces to negotiate different things? Time will tell. But at the end of the day, taken on the face of the legislation, we are concerned about, the medium to long-term consequences for access.
So let me ask you a medium-term question. Is this going to survive the federal election?
I have no idea. I don't think I can answer that. I can't answer with certainty.
Well, that's why we invited you here. We want the answer.
All right, well, thanks. At the end of the day, this will become a big political football, right? It's, I believe that the federal government and maybe amenable provinces, in BC has already indicated interest before their election. Looks like their election, the last time I looked, is kind of coming back with the NDP supported by the Greens. So one would assume that will move forward in BC. I'm not certain, but the Manitoba also has an NDP government. They may be very interested. Atlantic provinces have a lot of older population in need of diabetes treatment. So I think there's going to be an attempt to move this forward as quickly as possible, but it will become a kind of a wedge issue. You can see that if some of these agreements are struck, the positioning will be, well, you've got to vote for us, because otherwise, the Polyever will take away what has been, implemented thus far. So it's going to be very messy. And the unfortunate consequence for, this audience and for patients is that politics will probably trump kind of good policy considerations. Not for the first time, but
shocking.
Never happens.
No, shocking.
Yeah.
Now, Laura, do your members, do you worry about that there's going to be, we already have a postal code lottery, but it'll be worse. Some provinces will have a deal and others won't. And you'll have diabetes patients living side by side and having very different access.
Yeah, currently they do anyway. And what we don't want is this to make it worse, right? You're already in a postal code lottery, and you're already in a lottery of, do you have a job with good benefits or do you not? And we also know that diabetes affects people of lower socioeconomic status at much greater rates, and they tend to be where there aren't as high, good benefit plans. So there's already a big schism, and our worry is this will make it worse. So hence for us, when I testified at the Senate, was think about a do no harm clause, something around think about more fill in the gaps. Honestly, I didn't call it that. And we do actually have a letter in writing from the minister that says, despite the fact it says single payer, first payer, universal, that's not the intention. And the intention is not to walk away from private. But like Declan said, we said, this is great, and thanks for the letter, but that's not what the law says, right? And so for people who live with diabetes, first of all, we're already getting calls. I went to my pharmacist, and it's not free yet. Like, people do not understand. So part of it is managing expectations right now, Andre, is that people thought, well, this went in is law. So now I can just go, right? And particularly if you live with type 1 diabetes, your out-of-pocket costs annually are about $18,000. Okay, and if you live with type 2, it's about 10. So this is real cash in the jeans for people. So there is real promise here. And I do worry that people are going to exploit that and sort of say, well, listen, if you vote for us, you're going to have more cash in your jeans. And so we hope not. To me, it needs to be a comprehensive list. It needs to be do no harm. They have a great model in the dental plan. Sections 4 and 10 in the dental plan talk about that the private is protected. So it's not like they don't have a model they could use, but they chose not to make those amendments. So for us, I think it's helping to manage expectations. First of all, this doesn't mean right now your drugs are free, because that's what people are hearing. And so each province is going to be different. And then in each province, how do we talk to people who live with diabetes around why is this covered and why is that not covered? And honestly, how do we get them involved in advocating for more comprehensive coverage?
And it is interesting, I've written about this, how they have these two big health initiatives and they're funded very differently, as if we're in two different worlds. It is a bit puzzling. But
It is.
Christian, how much is this going to cost?
It depends based on the definition of the program itself. But if you assume that it's a universal coverage paying for the first dollar, essentially it's going to be all the sales of a pharmaceutical product prescription. So it's going to be 40 billion at the maximum based on current numbers. If you limit that to a certain therapeutic field, as it is now, diabetes and contraception. In fact, the federal government planned that it would be 1.5 billion, and it end up to be already 1.9 billion, and already in a budgetary process to increase the budget. So that just realized the improvisation behind how to finance this program long term. And it's part of the big question as well, because every resource that is dedicated to, in competition, what the provinces are doing, it's kind of it's going to be very complicated for the next health conference for all the premier and the health minister together to negotiate this piece and other type of funding in the healthcare system.
And the parliamentary budget officer said last year this would cost a minimum $11 billion, what the government's
based on the premise that it was not first dollar paid, and that was not exactly the same therapeutic field and the depth of the formulary as well. That's another variable that we have to take in account.
And Joan, what happens to private insurance when you start pulling out 11 or $40 billion? What are they left with?
Yeah, well, I'll just start by building on what you've said, Christian, in that in our data, we have in 2023 spent $2.1 billion on just those two categories in 1 year. So we feel that, maybe it's interpretation as to what this universal single-payer healthcare plan will be, but it's vastly underfunded. But what will employers do? So, when it's two categories of drugs, employers may choose to just simply not fund those two drugs, or those two categories. It's a bit difficult, though, because there will be a list involved, and so maybe there is possibility of funding the others. I think ultimately, employers won't be too fussed about this start of PharmaCare. If it does manage to be implemented and to grow beyond the two categories, I think that's when we start to worry a little bit about what employers will choose to do, whether they will continue to fund prescription drug plans or not. I mean, the same goes for the dental, right? In terms of, will employers stop funding dental because once they eliminate their dental plan, their employees presumably could become eligible for that. So we're in a period of a bit of, we'll have to see what happens, but yeah, ultimately it's up to employers. But at this start of PharmaCare, it's probably going to be a little bit of let's see how it unfolds, if it is put in place, what's it going to look like, what's the list going to look like, all of these unknowns.
And yeah, go ahead, do you want to jump in?
Yeah, I just wanted to add too that for people who live with diabetes, we're already hearing stories of people getting turned away from jobs or switch jobs because the impression is diabetes is a very expensive disease. And if you're going to hire on a new employee with diabetes, it's hard to get insurance for them. They're going to be expensive. It's the #1 drug category. And again, this puts the person with diabetes. There's already a lot of shame and blame and stigma around diabetes. And our big fear is this is really going to add to it, is that, well, now you're a very expensive category, so we're dropping you because you can get covered by this new plan. And when you look at the list, like personally, only one of my 2 drugs is covered. So what would I do? Now, I'm in a very privileged position. I could pay out of pocket. But many, many people can't. And so a little bit of worry here that if it gets dropped, it's only exacerbating the burden, not just financial, but the stigma burden on people with diabetes, that you're too costly an employee, we don't want you. And we're already hearing that.
And we know that from the US that people won't move their jobs because they can't get new insurance, et cetera. Declan, you want to weigh in?
Well, just on the issue of cost, I mean, I think we need to be very skeptical about the existing estimate of cost of these medications. I mean, there's an assumption in PBO that, our existing mixed plan will continue, I think PBO might want to go back and maybe do another study with different assumptions, which reflect the legislative intent. And the other caution I would throw out is that all government estimates they only go one direction, right? I mean, dental care is an example, right? The original estimate, I forget exactly what it was, but it's more than doubled, since the original estimate. So I think there's a lot of money here, and I think then we have to ask ourselves, because payers are always telling the industry like resources are scarce, like we need to do more with with the money we have. The way you do that is not by having a universal plan. It's by helping people who don't have coverage or who have inadequate coverage. I think that's a more strategic use of scarce public resources.
And I assume that direction is up. Oh.
I think you can. Yeah.
Now, you talked about the law before. You have a legal background, but the devil is in the details. It's in the regulations, right? And we haven't seen those.
Well, so you're raising an interesting question, because if you actually look at the bill, there's no real provision for regulations under Bill C-64, and the list of products is kind of outside the bill itself. So presumably that can be changed at any time by any government, right? Because it's just a administrative, policy statement. So it also raises the question, if you're a province and you're thinking, well, there's this money here, what do I do with this? Well, first of all, you have to, consider what is the government going to be next year or maybe next month, depending on what happens, and what will their position be. But also, this list, is it malleable? Can I ask for something else, even if it's not on, part of these categories? So there's a lot of, because of it, it's the administrative element creates flexibility, but it also creates uncertainty.
And we know provinces have already said, like Quebec has said, we just want the money. We already have
send us the
PharmaCare.
check.
Yeah.
Quebec and Alberta send us money, we'll manage.
And BC has said, we fund contraceptives, send us the money, etc.
Which may sound self-centered, but on the other hand, I mean, they are the people who have to run their healthcare systems, and they have to live with the consequences of a change to the federal program. So it's not unreasonable for them to say, like, we'll figure it out.
So I want someone to tell us more about PEI. I don't know if Christian or Joan, who's better, but tell us about the PEI model. Is that scalable? Is that a good model?
You want to start?
Sure, I'll start. So PEI model's been in place now a number of years, and really what it is a transfer of money from the federal government to PEI, specifically for drugs, but PEI decides what drugs it wants to fund, and it is a program that funds drugs for those without any sort of other, private payer or any other sort of coverage. So it's, a very good model, one that we would support, and one that gives PEI its independence on developing the formulary according to what PEIers need. So we tend to think it's a good model.
Just to add on complement of this, PEI still decide which drug they are listing, and they didn't forbid or ban private coverage. So people who have private coverage, they still get their drug as listed with their employer, while the government of PEI, with the federal funding, they are able to cover more people and more drug. And to put that in perspective, low impact budgetary impact for the federal government, because based on the population number, and also one of the population is pretty senior in this province, so low impact, a lot of people, and it was the most restrictive formulary in the country. So doing the experiment in PEI is naturally was the best case to set up that stage. To scale up to other provinces, obviously the list of molecule that is covered is very different from BC to Quebec. So just based on that, it's going to be also part of the negotiation that each province will have to take on with the federal government. So there's going to be quite interesting to follow.
And we don't know if formularies will be different province.
That's the thing. BC is covering roughly 4,000 SKUs, while Quebec is covering about 8,000 SKUs. So right away, you see the difference. So is the federal government will fill the gap with BC entirely, or compensate Quebec for listing more drug than the others? So it's going to be an interesting battle. And as I said before, the next constitutional table, that's going to be part of it.
And we talked PEI, talk about Quebec. What about the Quebec model, pros and cons?
Yeah, Quebec model as, I'm the only one from Quebec here, I can tell. So Quebec has the advantage that no one is left behind. So it has successfully coexist private and public coverage. It's not perfect, but at least when you, and the main complaint that people say, I would say outside Quebec, oh, the Quebec system is costly. Yeah, but when you look on the other hand, and I don't want to bring all the pharmacoeconomists in the room, but when you look at the cost of itself, hospitalization, visit to emergency and everything, if Quebec didn't have the comprehensive formulary that they have now, it would be even worse than what it is now. So when you compare from province to another, our cost of hospitalization and number of visits to emergency are lower than many of other provinces. So, it's a basic of pharmacoeconomy.
Quebec has the most broad public plan coverage in the country by far. So, when people say it's too expensive, well, people get better access to better treatments, and that, of course, has implications for the rest of the healthcare system as well. So,
Yep.
Yeah, it comes back to our cost-value question earlier. Yeah. Laura?
Yeah, and I would just say again, what we find is we talk about diabetes as a pool, and in Canada there's 4 million people in the pool, and some are in the shallow end and some are in the deep end. And we've got about 6 million people sitting on the edge with their feet in the water. Those are at high risk or prediabetes, and once every 3 minutes someone goes in. One thing that PharmaCare can do, it's exactly what Christian was saying, is actually, if they're going to go in at the shallow end, and if they're in the shallow end, keep them. Because what we do know is if you can't get on your drugs and you can't stay on your drugs because you can't afford them, you're going in the deep end. And the deep end is very expensive. The deep end is dialysis, heart attacks, strokes, amputations, vision loss. So this, again, when I was at the Senate, the question was, oh, you have this Cadillac version of the list you want. And the answer back was, have you seen the cost model? If everybody's in the deep end, that's where the expense is. So think of this as, yes, it's an investment. It's not enough. I mean, the 1.5 billion that they've said, diabetes alone is 4 million a year, and their 1.5 billion was over 5 years and included contraceptives. So, it's not even close. It really is it's budgeted as a fill the gaps. But what I want to say, Andre, before, is we're talking a lot about the negative here. I want to go back to where I started. For many, many, many people, this could be a huge step forward if we can get it right. We don't really even know because the data on diabetes sucks, but we really, we think up to 15% of the 4 million people in the pool are uninsured or underinsured. Okay, that's up to 600,000 people. So when you think about that, the promise of this is good, the execution isn't, but I don't want to give up on the promise.
And Joan, currently there's, the last I checked, 117 different public drug plans. There's a real bureaucracy out there. Is there something to be said for some centralization there?
I think they say there's even more different types of private plans out there. But you're right, there is a lot of variation, province to province, private insurer to private insurer, public to public plan. There's certainly some ways that we would like to see more comprehensive, and one of them might be negotiating brand prices for all Canadians. I'll say that again in this venue. But that would be one that...
You're very brave.
One we'd like to see, and I know there's something in this particular act about negotiating prices or bulk purchasing, I think is the way they phrase it. Maybe we'll get to that. But there is something to be said about making some, even a formulary that's consistent, at least as a basic minimum formulary from province to province, from private plan to private plan might be a good place to start as well in bringing some consistency to the marketplace.
Right. And Declan, we had a great presentation to open about rare diseases. The rare disease strategy has been around for a couple of years. There's only been one little deal signed.
Yep.
Do you worry about the same thing with a broader PharmaCare that's going to take forever to get off its feet?
I don't know if worry is the right word, but I think it will be complicated. I mean, the provinces, some of them already expressed skepticism. Some, like Ontario, are being very quiet about this and are clearly trying to evaluate which way winds are blowing, et cetera. So it will not be easy. As I said, I think they will try and get one or two kind of, jurisdictions off the ground who are more amenable to this to kind of create some momentum. But at the end of the day, like I said, the provinces are responsible for their healthcare systems. So, imposed federal lists of products are, I think not going to be graded particularly well by a lot of jurisdictions who may say they have other needs which are just as important. On rare, I think, what has happened there is really unfortunate. The strategy, again, it's a situation where the money is not nearly enough for DRDs, but it is something.
It's almost the same amount for both, 1.5.
But before there was nothing, so it's definitely better than nothing. They reached a sort of a memorandum with BC for, I think it was 194 million, covering 2 products, also other issues beyond products as well. So it's a start. But again, provinces are kind of, caught in a bit of a dilemma, right? Because, that funding is there for a few years. We don't really know what future governments will do with, what kind of guarantee of funding for DRD patients if it's a drug that's, not for acute, it's a chronic condition. So, at the end, provinces, recently I spoke to a provincial drug plan official, and he said delisting is just like essentially off the table. So they have to be very careful about what funding, whether it's through PharmaCare or through the DRD strategy, before they move forward, because they don't know what Ottawa will do next.
Yeah, they're worried about the Trojan horse. We just send it in.
They've been burned before, right?
Yeah. Now it's almost time for you guys to ask questions. If there are lots, we can start now. Anybody have a first hand up? Because I'll keep going. I got these big brains here. Okay. So let's see what else I can ask you. Now, I want to come back, Laura, about inequities. Do you worry, in some ways diabetes has won the lottery, right? You're first. But what about, heart patients? Aren't they going to say, what about us? And do you worry this creating these splits in the public, in the health sector between patients?
Yeah, I heard Christian mention that too. We haven't seen that so much yet. I think as major health charities across the country, we work together a lot. And I think this is sort of seen as there's a foot in the door and we're going to keep the door open. And it's better to have the foot in the door and get something on PharmaCare. So we haven't seen a lot yet. Doesn't mean it won't come, of people who are like, well, what about my disease? So I think it comes. For diabetes, it leads to heart disease, it leads to stroke, it leads to kidney. So in fact, it covers a lot of things, actually. And so again, with those organizations, we work a lot. So the more inequity I worry about is the haves and have-not financially, is that it's going to be easier, again, particularly if private plans stay, but this doesn't get off the ground, that schism is going to get bigger. Is that particularly as more new innovative drugs come, GLP-1s, that kind of stuff, they're really expensive. And they're not on the current list at all. And to Declan's point, that list isn't even in the legislation. It's a separate list. So that's my worry about inequity, is that rather than the promise of this, of the people who don't have access, it's actually going to backslide. And we've sort of held some promise in front of people. They're already, as I said, going to the pharmacy and asking for that. And then it's just going to go in the dust of negotiations that never went anywhere. That's, I think, the bigger inequity. Not so much disease against disease yet, because I think the idea would be, if this starts happening, then what next? But I think everyone's like, let's see if this even starts happening.
And Christian, PharmaCare is not just this legislation and the list, it's about purchasing strategies, et cetera. What about that aspect? Is that moving ahead? Is this part of the unspoken part of the legislation?
Another blind angle, I would say, they stated in the law bulk purchasing, but no one knows what that means, really. And what is funny is during everyone who watched the hearings on C64, like, no one talk about PCPA, and PCPA is playing that role actually of negotiating the best price. I'm sure many people in their room, they face current negotiation or past negotiation that were very difficult with PCPA. So could you imagine that would be different or worse or better with the federal government? What is quite surprising is they completely ignore during the hearings that PCPA exists. And when we ask the question as what's going to be the role of PCPA in that context? Oh, they will still negotiate price for products that are not listed. Yeah, but ultimately, it's going to be a kind of temporary, it won't work. Like, do you have a future? And they're already doing that. And the funny thing is the federal government is already participating into PCPA. So it's kind of weird how they go. And the risk is bulk purchasing, if you apply it, basically, it's going to be the low common denominator that will force indirectly to restrict to eventually some product to have an economy of scale. And both sides, like innovative or generic, has everything to lose in that aspect. It's going to be difficult to list new innovative product, while it's going to be very difficult to maintain or even increase product that has not get any price increase since many years. Take the example of metformin. Metformin is $1.32 per month for 30 pills of metformin. This price is the same since 26 years. They forgot about inflation. Oh, yes, we'll crunch the price down. How do you make that possible without creating a potential shortage? I'm not pushing the panic button, but it is a reality of economics, you know.
Joan?
Yeah, I was just going to add to that, of course, most of the drugs that we fund are generic or biosimilars, and we already have a negotiation that takes place between the Canadian Generic Pharmaceutical Association, CGPA, and PCPA. It was just renewed in this past year, I believe.
Yep.
And that covers the vast majority of drugs that we fund. You're right, PCPA still takes care of the innovative drugs that come to market, and there could maybe be some work done there. But yeah, as far as generics and that sort of thing, already market seems to be taken care of, one would think.
And what you're saying, the generic pricing framework is negotiated with PCPA.
Yes.
So,
yes, exactly.
And Declan, you want to weigh in?
Yeah, I would just say that, you know, there's an interesting dynamic in Canada between the private market and the public market. And, you know, their prices are generally speaking, you know, lower in terms of the public side of things. But on the other hand, I mean, this is, you know, this has a follow-on effect on the private market in the sense that, you know, there are more products available on private plans, which is presumably a benefit for patients on those plans. I think we can safely say that. And, you know, this whole discussion around bulk purchasing, particularly because little is known about it, like CDA is going to start a study. We've heard that we might know a little bit more in a few weeks. They've retained a consultant to help them. Don't know what that means, but all of this to say that discussion will start. But, you know, it is starting now. That plus royal assent for the bill is starting to cause some international concern. We are getting calls from outside of the country going, "What is this? What is going on? What are the implications?" And no offense, Guillaume, but similar to the situation we were once in with PMPRB, we kind of go like, well, that depends. We don't really know. There's too many variables. It's hard to figure out. So, you know, it will start to have an impact on eventually on product launches and companies' calculations, because they're now, you know, international HQs waking up and going, something is happening in Canada, and I want to know what that means. And if I don't know what that means, I'll plan accordingly.
Yeah, they're saying they've been talking about this for 70 years, and they're actually doing something. We've been, what's going on? Yeah.
Well, until something, I mean, it's human nature. Until something is actually like an issue, like until, well, it's a bill. When it's law, you can't really ignore that anymore.
And speaking of PMPRB, is legal action inevitable in this?
No, I wouldn't say so. I mean, you know, we'll have to see how this unfolds, but I don't think it's, you know, ultimately, you know, it's never the desire of the industry. When I was a really tiny young lawyer, one of my bosses said, you know, Declan, be careful when you're suing the customer. So it's never something that that people do, like, you know, for any kind of, adversarial reasons. We hope that it won't come to that. I mean, at the end of the day, I think we're all aligned in terms of getting better coverage for patients, particularly those patients who don't have, coverage or have inadequate coverage. So, there is an alternative that would avoid, anything like that.
I think I saw a hand go up finally at the back. Yep. See, now they're going to ask 10 questions because there's 5 minutes left.
So having access to a menu is great, but the question is like, what's in the menu, right? And my question is, currently, what is the definition of the federal government for essential medicine, and what are the indicators or information that are currently available on how they want to handle innovative medicine that are coming into the market? I'm thinking about diabetes. It's such a booming market right now. There's so many new launches coming. So how are they thinking about the future of innovative medicine in the context of PharmaCare?
I'll let you take that one.
So one of the many tasks for the CDA under the law is to come up with a list of essential medicines. So they're tasked with coming up with that, I believe, within a year of royal assent. So I think and then of course the government will have to decide what it does with that. So I think that's still work in progress.
And in Canada, in a rich country like Canada, that'll be different from the WHO list of essential medicines, I would assume.
Essential is like beauty. It's kind of in the eye of the beholder, right? It really depends on, is it essential from a, human health perspective? Is it essential from a, from some sort of socioeconomic perspectives? Yeah, there's a lot of, shortages. Also, the people are making lists of, drugs that are essential. So yeah, there's a lot of variability in those definitions.
And if I may, just one side of your question is about the list of essential medicine. Obviously, it's tied to the type of medicine that we have in Canada, right, but also tied into the drug shortage perspective. Actually, there's a lot of discussion more so on that side rather than being like in link with innovative medicine. That's another battle that you and your side of the business will have to make. But the essential medicine so far with Health Canada is more towards shortage of medication, which 70% of the time would be, because based on the usage, 70% of prescription are in Canada are even more are generic. So it's normal that there's more essential medicine in that group just based on usage.
Yeah, and I would just, from a diabetes perspective, I can't speak to that. What we are really strongly pushing is that list that got attached to C-64. It's not part of the legislation. It's really not comprehensive or fulsome. Diabetes Canada publishes the clinical practice guidelines, and what we did was we did a comparison between the medicines listed in our clinical practice guidelines, which is evidence-based, and provided that comparison to the government and said, if you're going to think about the most important tools in the toolbox pharmaceutically, like think of this list. When I was testifying to the Senate, I got the question, which was interesting to me, of, well, Diabetes Canada wants the Cadillac list. You want the Cadillac list. And so the way I answer that is really important. So as someone who lives with diabetes is not one size fits all, and it's taken me 8 years since my diagnosis to work through that list and figure out the combination that works for me. So if that list isn't comprehensive, for many people with diabetes, you're actually not going to get them to treat to target because you don't have the full list. So rather than thinking of it as Cadillac, think of it as what's the toolbox that the provider and the patient needs to really make their diabetes manageable. And I have no idea if that landed with that, because there is this sense of, well, let's get the cheap list, the essential list. But with diabetes, that's so hard because I'm not on insulin. There's a bunch of different kinds of insulin. So what we're trying to say is, why wouldn't you go with best evidence? And that exists in the clinical practice guidelines.
Other questions, comments? Yeah, over here on the right. Yeah.
Hi, thank you. Joanne DiNardo with Arthritis Society Canada. Great panel so far. Just question around value-based approaches to coverage. If we're thinking about the appropriateness of a list, do we think that we have a government that's amenable to that value-based approach, or future governments? Just thoughts generally on that approach.
Joan?
Well, I guess my initial thoughts, and great question. So you're hearing from Joan, not ZLHA, is that I don't see governments really any role for them in producing a list like that, at least not at the level that has been produced today. And to the value-based question, I think that definitely there's bright minds at CDA that could do that work very well. So perhaps we'll get to that, but I don't see that it's produced the list that we have today. I see many gaps in there and many old treatments, I guess I would say, not looking towards the newer ones. So there's some real work to be done.
Yeah, they've really stuck to the classics, right? Yeah.
Others on the panel may know more than me, but I think how the list actually got created remains the subject of some mystery, right?
Yeah, and we've asked specifically, and there is no answer. I mean, one of the things, Joanne, that I would say is it again seems to come back to there's two different buckets of spending here, and the ability to look at the value between them. Like if you invest, back to my analogy of people in the shallow end, they may not get to the deep end, and the deep end is where another bucket of money for hospitals and cardiac care and kidney and all. And it is often difficult to get those people to look at those two buckets and see the value in one to prevent increase in the other. This is just Laura. I haven't seen that happening here. And again, the comments around, but you want the Cadillac list, and you like, again, it's not patient-centered so far in terms of, no, what I want is someone who has no insurance or is underinsured have access to drugs that for diabetes are going to get them managed to target so they don't end up with those 5 main complications. That's not how it's being talked about.
So it's time for one last question from either one of you or from me. Going. Yeah, over here on the right again. You should have just stayed there.
Hi, thanks. Kelly Gorman. I'm also with Arthritis Society Canada. Just building on what Joanne had said, and it's a question I've asked before, and I haven't really received an answer. I'm just like, with PEI, is anybody doing an analysis to understand what the impact has been? Because it's been a couple of years now. So are more people getting the medicine, but then are they having better quality of life? Like what, getting back to that value base, like the health outcomes from what's happened. Because I just think it would be a really good case study, and I don't know if it is happening, and if someone knows, it would be great to share those results, because I think it could really help inform some of the future decisions that are going to be made.
I think it's a really good point, and it's a really good question. I'm not aware of anybody who's doing that work right now. It only came into effect, I believe, in August of 21. So it's only been a few years. So it may, the ability to study may be somewhat, limited at the moment, given the populations and the time that has elapsed since access got better. But it's an interesting idea. But I'm not aware of.
But we do know coverage is better.
Oh, absolutely, yeah.
Great. So, Declan Hamill, Christian Ouelett, Laura Syron, Joan Weir, thank you very much for your insight. Thank you for joining the panel. Please give them a round of applause. Thank you.